WFPHA, but today we're talking about allocating sustainable funding for resilient health systems and asking, is it a distant dream? We know that the lack of alignment between economic and healthcare worlds has resulted in inadequate strategy for sustainable healthcare investments. And numerous decisions that affect health are made outside the health budgets and also, of course, take into account areas such as land planning, transport, environment, and so on. And these will be elaborated. To start off with, I am going to introduce Professor Vivian Lin, who's the Executive Associate Dean and Professor of Public Practice at LKS Faculty of Medicine at the University of Hong Kong. Vivian has 40 years experience in public health with a variety of leading roles in policy and program development, health services planning, research, and teaching and senior administration in complex organisations. She was previously Director of Health Systems at the Western Pacific Regional Office of the World Health Organization and Chair of Public Health at La Trobe University in Melbourne before serving in WHO. And that's where I first met Vivian and where I learned to admire her work. She's consulted widely and with a wide range of organisations. She earned a Bachelor of Arts from Yale, a Master's and PhD from UC Berkeley. My pleasure to introduce Professor Vivian Lin.
Thank you so much, Michael. It's my great pleasure to join this esteemed panel and to be able to open the conversation. We often say prevention is better than cure, but if it's really better, then why is it we never seem to have enough money? And how might it be financed? And I think this issue is really all the more important now, taking on, I think, some degree of urgency in this post-COVID environment. When back in 2020, we talked about how we can build forward better. And now seems so many people are just desperately to go back to life as it were. And we know that is not the way to prepare for the future. So the key policy questions, I think that's certainly been important in my career in various contexts and conversations is, can we get a minimum or an ideal level of investment for prevention? And how do we finance it sustainably? The answers are unfortunately not so straightforward, but I want to start out by talking about how do we know what's actually spent, and then think about how should we spend it, and then how do we enlarge the pie. So I first started working on some of these issues probably about 30 years ago when I was the executive officer for the Australian National Public Health Partnership. But a more recent foray into the area was when I was Director of Health Systems. And, you know, we kind of had this dream. We thought what we need to do with 37 countries in area is to kind of really advocate for some minimum standard of investment. So, of course, the starting point is always the data. What is the minimum? Well, what do we actually spend now? So we undertook a study looking at total health expenditure. And total health expenditure is all public, all private, all out of pocket. And so we used national health accounts in order to do comparable definitions, and I will explain that in a minute. But essentially what we found was a huge variability across the countries. We actually never published this study because there was so much more work that needed to be done with the data. But roughly what we could see is that Australia and New Zealand, if you take two countries that in many ways have similar approaches to government, similar cultures and values, New Zealand spent twice as much as Australia did. And then you look at Korea and Japan, and there's two countries that are also, in a sense, somewhat similar in the way the health system works and culture, and they were comparable, and both were much higher than Australia and New Zealand. So this obviously raises that question of, what goes into all this? Now, the OECD, which I will also explain their system, in 2017 did an expenditure study using their system of health accounts. And what they found was that preventive care averaged about 8% in terms of total health expenditure across the Asia Pacific region. Australia, sort of bottom of the class at 2%. I can say that as an Australian. And Fiji was the top at about 20%. So this, of course, just makes it a little bit difficult to say, well, how much should you really spend? Now, just so that you're clear on these definitions, and there are these two systems, under the WHO's National Health Account system, there's a category of preventive and public health services. So by going to National Health Accounts data, you are getting comparable data from across countries. And if you just look at those dot points of HC 6.1, 2, 3, 4, 5, etc., those are the categories of expenditure. And the data is collected in that way. But if you go to the OECD and look at how they report current health expenditure, then this is their total taxonomy. But again, if you look at HC.6, they call it preventive care. And this preventive care actually looks quite different from the WHO. So if you're going to compare expenditure data, you need to decide whether you're going to do the OECD data, which is, of course, OECD countries plus any other additional studies they do, or you're going to go with the WHO's National Health Accounts in order to get that comparability. And one of the challenges in both systems is actually defining the boundaries. So you always just have to check the definitions. But in the 2017 study, I won't go through this in detail, but if you just focus on that light area, which is called preventive care, you'll see Fiji comes out very well on top. And then two to the right is OECD, and that kind of gives you the average. And you can see this huge variation across the different countries. This is total health expenditure. If you only focus on government and the compulsory insurance schemes, then there are certain things that drop out more. And you can see that the preventive care comes up a little bit more strongly because a lot of that is government expenditure, and the personal aspect of preventive services is often done through insurance schemes. But nonetheless, it's still highly variable and not very significant. Now, in the most recent National Health Accounts report from the WHO, they did look at spending during COVID. This is an extract from that report, and I won't go into it other than to flag a few things. The most significant is the yellow highlighted, which is that per capita spending on preventive care rose 32% on average across countries. So you can see that the countries were obviously responding to the pandemic, but here is then, therefore, the constant dilemma for public health in every country, which is when there's a crisis, when there's an outbreak, that's when the money goes up. And then quite often the money goes down after that. And, there's a couple of interesting things that also happened. During 2020, the out-of-pocket spending actually fell in that first year. And that's because a lot of people did not use health services, either because they chose not to, or because some governments actually stopped some services from being offered. I think the other quite interesting thing is that when you actually look at the expenditure on COVID, more than 40% was actually allocated treatment. And you'd expect that, of course, given the fact that people were hospitalized. In 2021, you saw more funding being allocated to vaccination, testing, and contact tracing. So this is where it's highly variable. And what we also know in many low and middle income countries is that they do not necessarily have a public financial management system where there is a surge capacity funding. So quite often in the lower and middle income countries, to actually get the funds to respond is not that easy. So first thing is, it's very, very difficult to know what's actually spent and to be able to compare. But then the question is, if you have the money, how should you actually allocate it? Because the approach we take to allocation might make a big difference to how much can you respond to outbreaks or to new health challenges. So traditionally, what we see is a lot of public health and preventive programs are organized in a very targeted way, what we might call vertical programming. It could be focused on diseases like tuberculosis and malaria, or on risk factors such as tobacco. Now, the advantage of this, of course, is you've got a clarity of purpose. You can set targets to achieve. But the downside is it becomes inflexible. It's a system for bureaucratic and political accountability. And of course, in the lower and middle income countries, this is quite often how the donors are financing, because it helps them with accounting and getting an outcome. But it often means that it's not necessarily tackling the priority issues that require attention from a prevention viewpoint. So as countries then graduate from the global health initiatives, and in the Western Pacific region where I've worked, this is, of course, a very important issue as countries move towards middle income level or upper middle income category. So the first thing you might do is to harmonize your program. So while you might still have specific services target to TB or malaria, you try to bring together the work, the shared functions like surveillance, outreach, the lab services, the health education. So that's sort of where we start with a lot of public health programs. But you can also target, of course, different population groups. And here you could specify the services. But exactly what services are included and how it's targeted is usually a matter of politics. And these political decisions may be informed, of course, by the social movements. So whether that is a way to assure prevention is really a matter of the kind of advocacy that goes on. Now, what we do know is if you're going to put money into primary health care rather than institutional care, such as hospitals, you could make the money go a much longer way. It's more cost effective to be focused on primary health care. But here again, we've been talking about this for 45 years. The countries that have had a strong primary healthcare system, like Malaysia, Sri Lanka, Cuba, and in the earlier days, China, you know, there have been very good health achievements, health outcomes. But in many places, primary care is still seen as only frontline. So it's individual clinical care. It's about when people front up to a clinic rather than the outreach and the prevention. So I think it's better to put more money into primary care, but you still need to be specifying. And in China, under the current reforms, what they have done is to specify what is a essential preventive health services package that the government will be funding, and that the funding can be tied to whether the targets are reached or not. So that's one way to incentivize and move things further. Many countries for a long time have also looked at a place-based approach where they say, here's your population, let's give you, an amount of money for each person. So it's a capitation system, go to it. In theory, if you had limited amount of money for a group, in theory, you would want to put more into prevention because it's more cost effective. You want more services to be based in the community. The reality of many capitated system, however, is that the doctors and the specialists in the hospitals hold more power. So when there's competition for constrained resources, or when resources are capped back, it's often those who are more powerful whose voices will dominate. So that's the health sector. So what else could you do to improve prevention? Well, we do know that social determinants of health are very important. So what can you do to perhaps encourage action from other sectors, whether that's housing or agriculture, environment, transportation? There are many areas where in South Australia, under health and all policies, they did argue that health sector expenditure keeps going up. And so by funding some other sectors, it's a way of actually managing the healthcare costs as well as improving people's health. But here, what you need is a good policy and budget process, as well as very well targeted policies in other sectors, which can really go to the prevention issue rather than just for perhaps the usual call on the money. Now, finally, we're seeing some quite interesting developments globally. We're seeing well-being budgets like New Zealand and Australia moving in that direction. We've had these health and all policies in Finland for 40 years, and now people are talking about health equity in all policies. And we do have in Bhutan gross national happiness rather than gross national product in the economic sense. So with this new evolving global discourse on economy of well-being, perhaps that's something we should be paying more attention to in terms of how do we see the prevention agenda in that. So if you've got the money, of course, one of the challenges is in many countries, the uncapped part is the clinical treatment, and that's the insurance. You see a doctor, insurance pays, whether that's a national insurance or social health insurance, whereas the prevention part is often capped. And when there's cost containment pressures or fiscal pressures, it's very easy to cut the preventive services. So the solution quite often is try to ring fence prevention and to figure out how to move towards a blended payment system in the uncapped part of the budget. Now, then countries put in health technology assessment systems, and we obviously want to get good value and make the money go further. But cost effectiveness analysis, which is at the core of it, is often comparing two drugs to treat, rather than say, using this drug versus actually using a prevention campaign on the risk factors. So we don't often deal with allocative efficiency, and sometimes we don't actually, it might be cost effective, but we might not be able to afford it in the budget, again, particularly in low resource environments. So it's important, but we still have to really work hard to get to that prevention angle. And then we can think about some other approaches to perhaps improving what we get out of the money, using evidence-based guidelines, which we have a lot in the clinical side, less so in preventive services, although there has been, you know, a growing amount of that. And the activity-based financing and results-based financing, which have become very popular, especially with many donors, it's still much easier for those individual clinical services rather than the population-based. So these continue to be some of the challenges that need to be navigated. So then I think we confront some choices. When we think about national budgets, when budgets cover both public health and finance in clinical care, then of course, public health is going to be squeezed. So then is it better to have a social health insurance system? Not necessarily, because then people forget about that the public health bit. But a country like Switzerland does levy social health insurance to create a health promotion foundation, thus creating more funding for prevention and for very targeted programs. And while we have a framework convention on tobacco control that countries do have to increase their tobacco taxes, then it's an opportunity to again think about health promotion foundations as we have in a range of different countries, as well as having a price signal. I don't know why my computer has died, so I'm on my iPad.
Okay.
So my last comment, which is what was on the last slide, is really, I think, 3 big questions that need to be answered. And I think our other panelists could help move some of this conversation forward with them, which is, how do we actually create value and maximize value? By this, I mean the best health outcome possible through financing measures. Second is, who should be part of the decision-making process? Surely it's not only Treasury. But how broad do we go to a participatory budgeting approach? And where's the constituency for prevention? And my last question is, how do we transform actually the way we deliver services and programs so that they are as efficient, as accessible and effective as possible? Because for the limited amount of money, we really want to maximize what we could get out. So I'll leave those as the big questions.